منها chest pain, منها abdominal pain, ومنها headache. And these are, we call them cardinal presentations because it's common. You know, it's one of the people come with them a lot. So you have to have an approach to these symptoms, to the symptom. How to approach a symptom, you know, and more importantly, for this emergency medicine lecture, is like when should you be worried and what should you be worried about? Okay. Let's talk about it for a second. So I'm going to categorize the types of headaches. We're going to talk about characteristics and burden of disease. I'll talk to you about the secondary types of headaches. So that's predominantly what I'm concerned about for a lot of the secondary headaches. And we'll talk about, you have to understand primary headaches and their treatments as well. So a lot of people have headaches. There's no one here who hasn't had a headache at one point in his life. But if people come to the emergency department a lot for it, it's depending on where you work, maybe the second or third reason come to the emergency department as a symptom. Most people will describe that they've had significant headaches, like 2 or 1/3 of people over a year. It's pretty common. Yeah. And for Saudiya, that's just people often report that they're having headaches at home, not infrequently coming to the emergency department. It's more severe. So headaches, also in the Greek known as cephalgia, is basically a symptom of pain. It just means pain anywhere within the head area, head or face area itself. It's not specific to anything. I think it's important to understand your brain actually doesn't actually have any pain sensors inside of it. People are often convinced my head is going to explode, this is something wrong with my head, I need a CT scan. Most of the time that's not correct or useful because it's not related to your brain, because the brain doesn't actually feel pain. You'll see that because a lot of patients have strokes, they don't have any pain, they don't, you know, there's ischemia in the brain, they don't feel it. It's a painless issue. Now, the pain is usually from the structures around it. We'll talk about that. And then, so understand that the structures around it are a lot of structures. So any one of these things can feel pain. The nerves, the muscles, the bones. Yeah, we'll talk about it. The meninges. So how do we classify headaches? Well, the big classification is primary versus secondary headaches. Primary headaches are usually headache disorders or syndrome or diseases that are usually chronic in nature. And these are the ones you talk about most often, are they're benign in nature. There's no specific pathological cause, at least on an anatomical level. Maybe on a cellular level, there's definitely pathology. On a genetic level, there's definitely pathology. But if you scan these people's brains, you CT scan them, you'll find nothing. They're normal. The migraines, the tension, the cluster headaches. Secondary headaches are the headaches we are more concerned about. It's a headache related to an acute medical or surgical issue, usually. And this is what we have important for us to focus on. They're not always dangerous, but a lot of times they are. They're the ones that usually kill you. And there are other types of headaches, depending on how you classify it, is chronic neuralgias or cranial neuralgias, which is chronic pain from abnormalities in the signaling and the cranial nerves. And the most common thing is like trigeminal neuralgia, but there's different ones as well. So it's important to understand most people have headaches. They're primary headaches. They have headaches because they have a headache disorder. Most headaches occur between a certain age group, usually younger patients, middle age patients. Most common type of headache is probably tension or migraine headache. It's the most common thing you read. But there are different type of headache syndromes we keep talking about tension, migraine, cluster. There's like actually 10s or 20s types of different chronic headache disorders that we don't talk about. Neurologists know about them, we don't as much. But the point is to understand there's a lot of headache disorders that are primary in nature, okay? And they have different presentations and they respond differently to therapy, and they all have nothing wrong with them anatomically if you image their brains. Okay? They have different risk factors, they have different response to therapy. And they have different criteria. So secondary headaches. This is what we care about. The secondary headaches are mostly headaches that are acute in nature and not in context of the patient's chronic headache disorder. Usually the thing we worry about is the things that are related to vascular abnormalities, subarachnoid hemorrhages, sometimes strokes, aneurysms, vasculitis of the brain. It's debatable if hypertension actually causes headaches. People think it probably doesn't cause headaches. Probably if you have a headache and you measure your blood pressure, it's going to be high because you're having pain. Probably hypertension for the most part doesn't actually cause headaches. because most people who are hypertensive are actually asymptomatic. They have no symptoms until they develop heart failure or like edema or get a stroke, and then they find out they have hypertension, or check their blood pressure and they find that when they're well and they find it high. So the most part, headaches are not probably, the headaches don't cause the hypertension, the hypertension doesn't cause headache, the headache causes the hypertension, if that makes sense, right? And then, and then you can have headaches that are non-vascular, obviously, from secondary causes, like increased ICP is pretty common, from tumors, from intracranial hypertension, and then even for low blood intracranial pressures as well. All of these things will cause headaches, secondary headaches. Headaches associated with substance use, we see that quite often. Ramadan, people stop smoking, stop drinking coffee, they get headaches, withdrawal headaches. People use stimulants, again, can get headaches from the stimulant itself. Infections, you get viral infections, often will give you headaches, cold, flu, whatever you want to call it. And then metabolic disorders, we see this quite often, with, like especially if they have hyponatremia, they come in with headaches. It's pretty common because they have some cerebral edema. Patients with carbon monoxide toxicity come in with headaches as a common presentation. So metabolic disorders will definitely cause headaches. And then again, facial pain associated disorders, and then cervical radiation from your neck as well, or any muscle or abnormality, or abnormality. All these things will cause pain in your face. I said cranial neuralgias are a different type of disorder, chronic in nature due to abnormal signaling. We think it's post-inflammatory or viral infections. So, how do you report someone with a headache? Well, I think the first thing to understand is, if you report someone with a headache, do you think try to figure out, is this presentation, is this related to a primary disorder or a secondary disorder? And then for primary disorders, they're usually chronic disease that requires symptomatic management, avoidance of the trigger. For secondary headaches, those patients will often require testing, whatever the testing may be based on what we talked about. So it's a pretty, history is the most important thing about headache. The first question is this headache new or old? That's the most important thing. And people fail to ask that, even though, if someone comes in with a headache, do you have headaches like this? Is this common or uncommon to you? Because like I said, it's a chronic, mostly like a recurrent disease. If they have this and it's just an exacerbation, then this patient probably just needs symptomatic management, relief of these symptoms. Whereas if this is new or different, then you have to be wondering, is this a secondary headache? And does this patient need investigations? Okay? So most people will come in with primary headache, if you're nothing to worry about, migraine, tension, or the other types of headache disorders that we talked about. Secondary headaches are what you need for it. So again, now I told you about what primary headache, where they occur, which age groups, and that's important. So if they occur outside of the age groups and the demographics, then you need to worry, because these are more likely secondary headaches. But I said most primary headaches occur in the younger age, running into middle age. So if you're young and you're getting headaches, it's a problem. Pediatric patients with headaches, unusual. New onset headaches above the age of 50, unusual. So these are patients you need to worry about. These are red flags. So when you ask, then you have to ask them about the headache itself, because we said headache disorders have a specific presentation. Migrainous headaches will have an aura or no aura. They'll have flashing lights. They'll have hemifacial plane. They'll have and then they'll have a headache that will come on with throbbing, whatever, and last a day or day and a half, and then get better, etc. Tension headaches are band-like in nature, associated with stress, poor sleep, exercise, whatever you want to call it. Cluster headaches will come in severe. Episodes of pain recurrent a couple of times a month. We'll talk about it. So if they fit this, then it's probably a primary headache. But if it doesn't, and it's different, then you need to be worried. Okay? They're what we call red flags in headaches, and we'll talk about that specifically right now. Things that make you say, this is probably not a primary headache, I need to do advanced testing for this patient. Okay? We'll talk about that. So, like I said, you have to ask what history is the most important part. Acute, gradual, sudden onset, rapidly progressive. Rapidly progressive headaches are generally concerning. We call it thunderclap headache. It's usually people say it's not really 1 second I have no headache, 1 second I have a massive headache. No, it's usually like a rapidly progressive over 1 hour headache. That's usually actually the proper description, which is usually unusual for most headache disorders. Sometimes that does happen with headache disorders, it can, but usually the patient it'll be usual for that patient. Okay? So the difference with that is, subarachnoid hemorrhage is what we care about a lot, because that kills patients. It can happen in any age group. Vascular malformation, same thing as well. Strokes can do that, but also cluster headaches can come in that picture. So severity again, tension headaches are not that severe. They usually are uncomfortable, relieved by rest or sleep or mild analgesic. Cluster headaches are actually quite severe. The patient comes in crying and screaming in pain, but that's not unusual for them. Migraines can be moderate to severe as well. Frequency and duration, again, usually tension will come when you can identify a trigger, come and go. Same thing for migraines. There's usually a frequency and duration. They don't last more than usually a day and a half to 2 days at best. Tension usually lasts a few hours. All right, so it has to fit a certain. If a headache's been going on for 5 days or a week, then you should be concerned. Location of the pain. Again, you need to know where these headache disorders will cause pain. So if they're out of this location, you have things that's probably not the cause. And then specific locations are concerning. We have headaches that are associated with the temporal pain. Then we think an older patient think about like vasculitis, temporal arteritis. That's unusual. Headache that goes down into the jaw, causing the jaw pain. On mastication, again, vasculitis associated pain. There are other things. Headache with associated neck pain. You think about dissection will cause that kind of headache. So there's certain locations of pain that make you worried. Okay. So history, again, very important. You need to understand their past medical history, because certain past medical history will make people more predisposed to secondary types of headaches, right? So if someone has cancer and they come into a new type of headache, like metastatic cancer, most often it's related to metastases to the brain. That's the most common thing actually having onset headaches. If they have history of meningitis, that can happen again. They have a history of immune suppression or HIV. It's again probably a secondary headache, it's not a primary headache. Lymphoma, same thing, malignancies. If you have intravascular disorders, somebody's had strokes in the past, they come with a new onset headache, you have to worry about any stroke or a bleed. Again, yeah. So hypertension puts you at risk for strokes and bleeds as well. If they're on anticoagulation, they come in with a new onset headache, you have to be worried about a bleed. Makes sense, right? If they're using medications chronically and they stop taking medications, that's also a common cause of headaches. If they chronically use benzos, they chronically use stimulants, and they stop, they'll often have rebound headaches with those medications. Same thing for like cigarettes or any stimulant use, or coffee. And the history of trauma with headaches, again concerning. Not all of them need imaging, but trauma itself will cause new onset headaches because you have concussions, usually are associated with headaches. And some of them need obviously imaging because we're worried about a bleed or cerebral bleeding after a traumatic event. And then also procedures. Post-lumbar puncture headaches is quite common. They're quite severe, debilitating. They'll come in, they'll say, I know I had a procedure, I had a cesarean section, I had a knee replacement, and now I have severe headaches. They usually have a CSF leak post-lumbar puncture, which is not common. So you need to ask them about triggers as well for their headaches. They're usually common triggers for common headache disorders. And family history as well is associated. And again, psychosocial history is important: substance use, exposure, job, etc. Sleep pattern. So physical exam, obviously, for anyone you see the audit or in the clinic, firstly comment about how does the patient look. That's the first thing you see. They look well, they look in distress, they look like they're about to die. It's important. It's actually one of the most, how do they look to you? Is the most important thing you can comment about. But then you need to comment about their vital signs. Someone says, he has a fever, I think it's just a tension headache, and then, his blood pressure is 200, he has a fever, he's hypoxic. It's not a tension headache, there's something else going on, right? There's something, so the vital signs are always important in these patients, especially fever is an important one. And then, video cardiovascular assessment, that's more of history really. ENT exam, people fail to do this all the time. Like I said, brain mostly doesn't feel pain, it's referred pain for the most part, so they might have just a tooth infection, they might have something wrong with their salivary gland, they might, so an ENT, they might have otitis, it's not uncommon, then they come in with headaches, these are common presentations. And then, looking for, actually physically palpate the face to see if you can reproduce the face. Temporal arteritis, if they have like mastoiditis as well, and sinusitis, like these are. And then, not all patients, but some patients, they come in with headaches and they actually have acute angle closure glaucoma. It's not an uncommon presentation where they come in, they'll complain about severe headache, but actually what the problem is that their intraocular pressure is very high. This is often missed, and it comes in exams. You'll see this often. They like asking this question. So this drives me crazy. If you see someone with a headache, it's a neurological presentation. You need a full neurological exam. If you want to fail a station, if you want somebody to leave a headache and you don't do a full neurological exam, you'll fail that station automatically. Obviously, it's like saying somebody has abdominal pain and then you don't examine the abdomen. It's just a great way. And people are uncomfortable with neurological exams, which is why they don't do it. So you have to at least have a good approach to it. You're not a neurologist. You're not expected to do, vibration and fine motor versus coarse motor sensation. But the point is, there's supposed to be at least a comment about cognitive assessment, cranial nerves, motor function in all extremities, at least estimation of strength in all extremities, a comment about tone and reflexes only if appropriate, and then gait needs to be commented about, needs to be gait, and cerebellar testing, and cranial nerves. These have to be part of it. And a comment about neck being supple or not versus, meningitis findings, all right? This is the basic neurological exam that you need to do for someone with a neurological presentation, whatever it is, in the emergency department, or even in an outpatient setting. Because if this is abnormal, this is not a primary headache, right? If anything here is wrong, primary headache should not cause any of these things to be abnormal, okay? So red flags, you'll hear this term used for like back pain, abdominal pain, but for headaches is, what are the symptoms that a patient comes in with, or history or risk factors that requires neuroimaging, okay? So these are the things that say this patient needs a CT scan. Generally, if you thought it's a CT scan of the brain, that's the first thing we do. So it warrants further testing, but predominantly neuroimaging, that's what it's saying. So, new onset headaches after the age of 50, concerning. There's a lot of disease pathology. They're less likely to have tension or migraine headache because they should have had it already. But new onset after 50 is a concerning finding. It's usually associated with mass lesions. Sudden rapid progressive headaches, vascular abnormality, vasculitis, subarachnoid hemorrhage, so concerning. Intractable headaches lasting many, many days, again, neuroimaging. Patients with risk factors for intracerebral pathology who come in with new onset headaches. HIV, anticoagulation, right? Severe head trauma, whatever. Infections that can cause, CNS infections, that can progress, and people with malignancy. These patients all need neuroimaging, okay? Make sense?
Yes.
Yeah. Systemic illness, they have signs of sepsis, and they come in with a headache in neuroimaging for brain abscess, and then early workup to do if there's going to be lumbar puncture. Focal neurological deficits with a headache, somebody comes in and he's hemiparetic and he has a headache, they need a CT, right? They have a new facial palsy, they need a CT. Basically, if they have abnormal pupillary exam, they need neuroimaging. Anyways, so you can see, like minimal exertion headaches that are new also need imaging. So lab testing. Most patients who have headaches don't need testing because there's no point. There's nothing. You're not going to find anything. Someone who has a tension or migraine headache, testing them is not going to change anything for you. So you probably shouldn't test them. You should just treat their symptoms and send them home. But depending on what you're concerned about, if you're concerned about infection, if you're concerned about bleeding, etc., then you're going to get CBC. If you're concerned about inflammatory vasculitis process, you're going to get inflammatory markers. Like I said, the neuroimaging is not warranted. Most patients who come to the emergency department don't need neuroimaging by a fact, because most patients have primary headaches. That's what I'm saying to you. So they have chronic headache. Getting 50 CT scans is just harming this patient. They probably don't need any imaging. If they need imaging, it's usually done as an outpatient by a neurologist. We don't do it for most. CT scan, non-contrast is the primary modality of choice because you can see most acute pathology. You can't see everything, but you can see most things you want to see. MRI is a better test for headaches, generally, but obviously it's more costly, it takes more time, it's not readily available. But patients who have chronic headaches that are persistent for a long time probably should have an MRI, because sometimes even people who we think have primary headaches will rarely have like a mass or lesion underneath that. But usually that's done in an outpatient setting with a neurologist, okay? Lumbar puncture used for patients who have increased ICP, because that's how we measure ICP.
If somebody came to ER stable, only with a headache,
Yeah.
can I do in the ER MRI?
Why?
has headache.
Okay. Is this a new headache?
Yes. No, he's frequent.
So why would you do it for thought? Thought is not a place to treat chronic conditions. You treat symptoms. He's coming in because of headache. He wants pain relief. Treat his pain. Refer him to his family doctor. Refer him to his neurologist. They can do it. You know, you're here to see sick patients. That's generally what it's for, right? Same thing like someone who has hypertension or diabetes. It's not your job. You know, these are chronic diseases. You know, and if they come in DKA, you're going to treat them. But if they come in high blood sugar, you're not going to start them on insulin and adjusted medication. That can be done as an outpatient setting. So lumbar puncture, again, important. You think meningitis, increased ICP, subarachnoid hemorrhage has a utility in these diagnoses, obviously. Tonometry, or basically measuring the pressure in the eye if you think there's eye pathology and you think this is acute ankylosing glaucoma. Okay. So just talk about, I'm talking about the headache disorders. You can read more about it yourself. You just have to understand what the primary headache disorders look like, so you know what looks normal and what looks abnormal. Because if you don't know what normal looks like, you're not identifying abnormal, which you care about. So migraines, mostly unilateral, familial in nature, worse more in women, middle-aged. Some have an aura, some don't have an aura. Usually lasts up to 72 hours, up to 2 to 3 days maximum usually. And they usually feel unwell before. They usually have triggers, and people who have migraines usually have triggers that they know will bring on their migraines. Okay. Associated with physical stress as well. We don't know why they happen, but the theory is we think it's abnormal depolarization in the brain. There's a lot of different theories, but the most common thought one is that the brain depolarizes abnormally. That's why you get this pain. People used to think it used to do with abnormal like contraction and relaxation of the vessels in the brain, but we think now it's more abnormal depolarization of the brain. Anyway, so there's like anorexia, photophobia, nausea, etc. Usually the photophobia is pretty significant in migraines, headaches. Some patients with migraines will actually have neurological symptoms. They'll actually have this hemiplegic migraines where they come in with, they'll have weakness and numbness on one side. But this is not a diagnosis you're going to make. If somebody comes in the migraine with hemiplegia, you're going to image them and call a neurologist. But sometimes you can see it, and they'll have acute neurological symptoms with their migraines, actually. Just so you know that. They usually have phases. They have a prodrome, aura, pain, and postdrome. Like yourself. They usually it's mostly described as a pulsatile unilateral headache behind the eye. That's fine. Forget about it. They have abnormal visual observations like scotomas, flashing lights. I don't need you to know this per se, but if you're maybe family medicine or neurology, you need to know there's the criteria for migraines with and without auras. They used to like asking that in exams, medicine, a lot of. But the point is to understand that this is how you say that this is a migraine or not a migraine. And then all of them say, not better accounted for any other diagnosis. That's how basically I think there's nothing else to explain it. Migraine with and without an aura, okay? And the point is to say you have to understand generally what migraines look like to understand when it's abnormal. Things we miss, like we'll call migraines or temporal arteritis, cluster headaches, glaucoma, meningitis, subarachnoid hemorrhage. We'll make mistakes and call them migraines, and we'll miss these dangerous diagnoses. So mostly trigger avoidance, again, because usually are triggers. They're usually responsive to NSAIDs. Paracetamol doesn't seem to work that well for them. We have prophylactic medication, triptans, and Airdox will work for these patients, and there's some more advanced therapies now for migraines as well. What about that? In the emergency department, we mostly give them some fluids, and we also give them antidopaminergics. Metoclopramide has a chifloctachin, Maxaran, for headaches. It's an antiemetic, but also has the dopamine probably has some effects on the depolarization. We don't know how it works, but it improves migraine, different types of headaches, but it's specifically migraines. NSAIDs work quite well for these patients. So some people are on prophylactic medication because they have very severe migraines. Some people are on beta agonists, some people on tricyclic antidepressants, valproic acid. All these things can prevent migraines from happening. There's a lot of other things, and this is not the point, just to say. NSAIDs are the primary treatment of choice for these patients. Sinus migrainosis. Some patients will have migraines that will last more than 3 days and up to 5 or 6 days. In those patients, we will give them steroids. We sometimes see that. Tension headache may be the most common type of headache. We think it's due to abnormal contraction of the muscles of the scalp. Usually there's some sort of stressor involved for men, stress, psychological stress. There's also criteria to say this is a tension headache. Anyways, a lot of treatment for tension headache is actually psychological, it's not physical. A lot of people, psychological stress will bring on these headaches, so trigger avoidance is a big part of it, relaxation techniques is an important part of it, and then some patients will actually need medication. Cluster headaches, we don't see them that often, they're actually not that common, but they're very dramatic when they, it's predominantly male disease, we don't know why it happens. Anyways, it's familial in nature, usually young males, it's pretty dramatic, they come in crying in pain, they come in every couple of months. Usually unilateral, severe. There's always some neurological manifestations locally with it. We'll talk about it. Anyways, retroorbital, and usually come in clusters of 3 to 4 times in a month, and they'll come in for have to come to emergency department for it. Also, what's interesting is that it seems to it improves with, it comes in like I said, autonomic symptoms. They always have pupillary dilatation, they have lacrimation, they have facial flushing on the side. That's part of the cluster headache syndrome. Anyways, they also specifically respond to oxygen. It seems to improve their symptoms quite a lot, so that's why we give them oxygen. And they're the only subtype of headache that respond to oxygen. There are specific treatments otherwise that work for them as well. Basically, this is kind of like the most common headache syndromes that you just need to know about, what it looks like, how we treat it. This is kind of how the presentation of the pain will look like for these different types of pain. So this is some take-home points for this talk. Is that the most headaches are chronic headaches, and the point is to understand what their chronic headaches look like. We worry about patients who have new headaches or change from their baseline headaches. Those are who you should worry about. If you have rapidly progressive headache, then you have to worry about the thunderclap headache, and those require neuroimaging, so red flag. Cluster headaches always have autonomic abnormalities. That's the common presentation for them. Patients with migraines, specifically migraines, more than anything else, is they usually have specific triggers, so they often need to keep books and check what it is that's triggering their headaches, so to kind of avoid them. And the most important thing is, you want to figure out if this is a primary or secondary headache to decide, do they need imaging, do they need extensive workup, okay? That makes sense?
Yeah.
All right, so then let's do the last one.